Welcome to today's presentation. Today we're going to discuss depressive disorders, anxiety disorders, and obsessive compulsive disorders. So first we will take a look at our depressive disorders. So when we're looking at this overall category, there's some common features. So people often will present with that sad, empty, or irritable mood. And notice that that irritable mood might be important because you might not see a typical sad, empty people stating that they feel depressed, but they might have a lot of irritable symptoms. This can be accompanied by somatic, that's the body-based sensations, or cognitive changes. So sometimes we see people who don't necessarily report the mood, but they might report more of the body-based symptoms, such as having stomach aches, headaches. Those are probably the two most common, but also a lot of just feeling very tired or that irritability. But that tired, stomach ache, headache, that kind of thing is the somatic symptoms that might often accompany a depressive disorder and might be what people come in talking about. If it is a body-based symptom, I would make sure that they rule out any medical issue, and then you can focus on the mental health challenges after that has been screened out. It is also important to note that the depressive disorders will often significantly impact the ability to function. So we will see people who can't go to work, can't take care of their kids, can't do their day-to-day activities. That's the part that often could bring people in to your office for treatment. It might not always be quite that severe, but you'll notice often that decreased ability to function. The things that's going to distinguish in between the different depressive disorders is the duration, how long the symptoms are lasting, the timing of it, and the presumed etiology or why that's happening. So we're not going to take a look at all of these specifically, but within this category, we have the things that you can see on the screen. I don't need to read all these to you. We'll talk about the ones that you're most likely to see, but we won't talk about every single one. For example, when we look at other specified or unspecified, that's going to be more up to you to take a look at. And if all of the other depressive disorders don't fit, but that is obviously the person's main issue, then you can use one of those categories. But we're not going to really specifically talk about that or the due to another medical condition. We're going to look at some of the other ones instead. So the first on that list is the disruptive mood dysregulation disorder. And just like our DSM is structured with kind of the lifespan in mind, where things in childhood are earlier in the DSM, within the sections, things that are seen earlier in life is often earlier in that section of the DSM. So this is one that we will often see kind of in the younger time periods, middle school and middle school and high school especially. But what we're going to see is that this is characterized by the chronic, severe, and persistent irritability. And irritability is often what we see instead of depression or depressive, sad feelings in children and in teenagers. So that irritability is going to be something that keys you in. If you hear that with children, you might want to look at this. The key symptom is the frequent temper outbursts that can be verbal or behavioral. Note that these will occur an average or 3 or more times a week for at least a year and in at least 2 different settings. And that 2 different settings is important because it is possible that someone might only have maybe those frequent temper outbursts at home or only at school. If it's occurring in one setting only, we want to see if there's something happening in that setting that is causing that child or that person to have those temper outbursts or that increased irritability. So for example, if it's something that's only showing up at home, we might guess and explore the possibility that there's something going on at home that is causing some problems for the child. We won't diagnose this for children under the age of 6 or after the age of 18. And in general, this is a little bit higher in males and school-aged children. Note that there are high levels of comorbidity in a whole bunch of different categories, but do make sure that you differentiate between bipolar and oppositional defiant disorder. Those are two that are often confused with the disruptive mood dysregulation disorder. The next one is probably one of the diagnoses you will see the most in your therapy office. So, the major depressive disorder, sometimes people just categorize this as depression. Sometimes you'll hear people say MDD. So, that is one you will see quite a bit. And that requires 5 or more symptoms over at least 2 weeks, often much longer. So you're not usually going to see people coming into your office for treatment if they've only been feeling this way for 2 weeks. It's usually going to be a much longer period of time, maybe 6 months, maybe a year, something like that. And there are many, many different specifiers for this. So that is another area that you might want to explore a little bit just to see the wide range of variety that you can have for those specifiers. So, in addition to things like mild, moderate, severe, you're going to have things like with anxious distress, with mixed features, with atypical features, potentially with catatonia. So, note those, and also note that there are specific ICD 10 or ICD 11 codes listed in your DSM for those specifiers as well. Insomnia or fatigue are very often complaints, and that might be regardless of whether the person is sleeping a lot. So you may see that people are sleeping for 10, 12, 14 hours, but they're still very fatigued. Or they always feel sleepy, but they can't actually fall asleep, or they're waking up a lot in the night. So they might have the insomnia piece. Sometimes that symptom of sadness is denied. So people might say, yeah, I'm really not feeling sad. But once you start talking through them a little bit more, and especially your first couple of sessions, you might hear things described as hopeless, discouraged, down in the dumps, that kind of language. So that might be a cue to you if you hear someone say they're really feeling hopeless, that this might be what's going on. In children, you're going to see that irritability more than sadness. Make sure to distinguish that from the one before this because the irritability is present in both. And you might hear some discussion or symptoms of a loss of interest or pleasure. That's a very, very common symptom that people say all the hobbies they used to enjoy, they no longer enjoy. Or yeah, basically that kind of thing. The things that they used to enjoy, they're no longer enjoying. So there's something going on there. We might hear that there is an impaired ability to think, concentrate, or even make minor decisions. So a lot of people will talk about feeling foggy, that they can't concentrate, maybe they can't stay on any specific task, they're jumping in between things. Or maybe they have trouble even making minor decisions. So what you might hear is something like, when I get up in the morning, I just cannot decide what to wear. There's too many options. I can't make a decision of what to wear today. That kind of a thing might be those examples of minor decisions that are difficult. It's very common to have thoughts of death, suicidal ideation, and potentially suicidal attempts. Definitely screen for suicide with your clients that have MDD. Not something to freak out about, but definitely something to explore and screen. There's a 12-month prevalence around 7%. Females tend to have higher rates. I do sometimes wonder if that is because it is a little bit more acceptable in our society for females to feel depressed or to say that they have depression. I do kind of wonder if males might not have that just as much, but it's not as socially acceptable to say that you're depressed. So just something I'm curious about, not something I have any specific facts for. The first episode of depression might occur at any age, but incidents do increase around puberty. The peak tends to happen somewhere in the 20s. So that is an age range to look out for the first time people are coming in with this diagnosis. If you had someone that at 70 was coming in for the first time saying they were depressed, I would want to get a little bit more history around that. This is definitely a diagnosis that has reoccurrence. So it's a diagnosis that can go into remission. So it's something that can actually go away, but it can come back. So with some diagnoses, it's kind of a lifelong diagnosis, such as our personality disorders, our schizophrenia, things like that. But major depression is something that can be treated, can go away, but could come back. The impairment can range anything from very mild to a complete incapacity to attend to basic needs. Do note that in some cultures, the somatic complaints will be the primary symptom reported. So if you are working with a culture where it's not as socially acceptable to have mental health challenges, you might hear more about the somatic issues. So the stomach aches, the headaches, the feeling tired, something like that. So again, make sure if that is the primary symptom that you have them do a medical screening, make sure there's nothing else going on there. But know that that is very common, that it is those body-based complaint that's going to bring someone in to have some support. You might have people that come into your office with a persistent depressive disorder. We also call this dysthymia. And this is kind of a combination of a couple of our old diagnoses from the DSM-4. Chronic major depression and dysthymic disorder were kind of combined into this version of dysthymia. The depressed mood most of the day for most days for at least 2 years. That is going to be your primary thing to look at. And that length of time is the thing that's going to distinguish it from the MDD. In children, that primary symptom is going to be that irritable mood for at least 1 year. Again, they may describe their mood as sad or down in the dumps. They might not use that language, so keep your ear open for some of those other phrases. DSM-4 was around 0.5 to 1.5% prevalence. So it's not something that's quite as common, but with people that have said that they've had MDD for 5 years, it's probably something that you should look at. It might be more appropriate to have a dysthymia diagnosis. There is a high risk for comorbidity, especially for anxiety disorders and substance use disorders. So we often will see people in all three of the categories we're talking about today try to do some kind of self-medication, often with different substances. So that is another area that might be important to screen out. Interestingly, in our DSM-5, we now have the premenstrual dysphoric disorder. So during most cycles, at least 5 symptoms are present in the week before the onset of menses, and they start to improve within a few days, are minimal or absence after the end of someone's period. So we're going to have essential features of something like mood lability, so that really quickly shifting and changing moods, irritability, dysphoria, or anxiety. Any of those could be present. You must have some kind of adverse effect on work or social functioning. So this is something that is causing people to either have poor functioning. So maybe they are able to go to work, but they just don't function very well at work, or they just can't even go into work. Or that could be more in the social area as well. This is very rare, but at times we have heard of delusions or hallucinations. So again, that can be rare, but if you hear that, it could be something to explore. And it tends to not be a culturally bound disorder. So another thing to keep in mind. Shifting over to anxiety disorders. These are diagnoses that share features of excessive fear and anxiety and related behavioral disturbances. So fear is the emotional response to real or perceived imminent threat. Anxiety is anticipation of a future threat. So in anxiety, people are often thinking about the future and worried about a threat coming in the future. They differ from each other in the types of objects or situations that cause fear, anxiety, or avoidant behavior. So our different diagnoses are going to be diagnosable because of those differences in those three areas. And again, our chapter on anxiety is arranged developmentally. So the first one we're going to look at is the specific phobia. That is a marked fear or anxiety about a specific object or situation. And the really important part for that is that it is out of proportion to an actual threat. So it could be something like someone has a phobia about thunderstorms or lightning. They're worried that they're maybe going to be struck by lightning. So it comes to that point of being out of proportion if, say, anytime it's cloudy, they refuse to go outside because they're afraid that suddenly a thunderstorm is going to happen and the lightning is going to happen and strike them. It's very unlikely that if it's just cloudy outside, they're going to get struck by lightning. So it's out of proportion to that threat. And then it could also, well, it does have to cause clinically significant distress or impairment to functioning. So if any cloudy day, they're unwilling to leave their house to drive to work, they're going to miss a lot of work. So that's going to impair their functioning. This could follow a traumatic event, which would make it kind of a little bit more logical, but it's still going to be something that's out of proportion to the actual threat, as well as causing that distress or impairment. It is not unusual that people have multiple specific phobias. So if you hear that, don't be surprised. Prevalence is fairly high, it's between 7 and 9%. And this can look different in between cultures. One that you are going to hear and see a fair amount is our social anxiety disorder or social phobia. Here, our essential feature is a marked or intense fear or anxiety of social situations in which the individual may be scrutinized by other people. So in this, people are concerned that they will be judged as anxious, weak, stupid, crazy, boring, intimidating, dirty, or unlikable. So this is when some of those negative cognitions about a person can come in. So they might say to themselves, oh, I'm stupid, or oh, I'm weak, or oh, I'm not a very likable person. And because of that, they start to become more and more afraid of being around other people. They might be showing symptoms such as blushing, trembling, sweating, or staring. And in children, this can happen quite a bit in peer settings. This again is a fairly high prevalence. The 12-month prevalence in the United States is around 7%. The median age of onset is around 13 years. So we start to see this come a lot in around middle school time periods. This could be something that contributes to elevated rates of dropout, decreased well-being, issues with employment, workplace productivity, social economic status, and quality of life. So you can see lots of different impacts of the social anxiety disorder on people and their functioning. Panic disorder is one that, again, you might see fairly often. This is characterized by recurrent and unexpected panic attacks. If you've never had a panic attack, good for you. I hope you never do. That panic attack is an abrupt surge of intense fear or discomfort that reaches a peak within minutes. So it happens very suddenly and becomes very, very intense. The frequency and severity can vary, so it could be multiple times a day, could be once or twice a month. Let's see, I'm going to take a peek at the DSM real quick and see if there is okay, at least one of the attacks has been followed by 1 month or more of that worry about you having an attack or a maladaptive change in behavior because of the attack. Okay, so that's good to know. Yeah. Always go back to your DSM if you are not sure. Oh, and I didn't change this one page. It's not page 211 anymore, but take a look at page 235, and that's where you will see the cultural related diagnoses kind of at the end of that section. Generalized anxiety disorder is probably the anxiety disorder you will see the most. In this area, we have an excessive anxiety and worry about a number of different things. So it's not restricted to one category of things like a specific phobia. It could be a whole bunch of different events or activities. But again, we're having some of that same level of importance placed on the intensity, duration, or frequency of worry because it has to be, again, out of proportion to the actual likelihood or impact of that anticipated event. In our generalized anxiety disorder, we're going to see that the individual finds it difficult to control the worry. Because of that, it's going to interfere significantly with psychosocial functioning. Often we see this accompanied by things such as restlessness, feeling on edge, feeling very tired, difficulty sleeping, and again, irritability. We see our prevalence levels there, a little bit different between children and adults. Medium age of onset is around 30, but it really is a very large range. We see this slightly more often in females. And we'll give some examples when we talk about this a little bit more. Last category, we're just going to talk about a couple of these, but our obsessive compulsive disorders include all the things that you can read here on the screen. Hoarding disorder is new to the DSM-5. A couple of these other ones are very specific but very interesting, such as the hair pulling and the skin picking. That might be something that you see on top of another diagnosis. So again, lots of comorbidity here. For our OCD category in general, this is going to be characterized by the presence of obsessions and or compulsions. So we have our definitions here just because I wanted to make sure you see the distinction. Our obsessions are recurrent and persistent thoughts, urges, or images that are experienced as intrusive and unwanted. So this is really the things going on in the mind, the thoughts, the thinking that's stuck and you don't want it there. Our compulsions are more the behaviors, so the actions that people are doing. Repetitive behaviors or mental acts that an individual feels driven to perform in response to an obsession or according to rules that must be applied rigidly. So we often hear, well, let's go to the actual diagnosis. Okay, so for our actual diagnosis of just obsessive compulsive disorder, not the whole category, but the specific disorder, you'll see that on page 265 of the DSM-5-TR. You will have the presence of obsessions, compulsions, or both. So it could be one or the other, it could be both of them. But they do have to be time consuming. So they take more than 1 hour a day. And this is when things become diagnosable as opposed to just maybe a symptom. So hand washing is a very common one. People might feel like there's germs and they need to wash their hands all the time to get rid of the germs. Hand washing in general, not a problem. It's a good thing to do. It's a good thing to wash your hands after you're in contact with different surfaces or whatever. But if it takes more than 1 hour a day to wash your hands, or you're doing it so often that your skin is becoming raw and chapped, that's when it's an issue. So that's the kind of the level of distinction between when things become diagnosable. It's often associated with a reduced quality of life and high levels of social and occupational impairment. So you can kind of see that. So if someone's washing their hands for an hour a day, that could make it difficult to do your job, something like that. Prevalence about 1.2, slightly more in females. Age of onset, about 20 years old. 25% though have some symptoms or could be diagnosed by age 14. Do note that abuse in childhood has been associated with OCD. Screen for trauma. If trauma is the main issue that's causing some of these OCD behaviors, I would focus on trauma-related treatment. Because again, we're going to have that comorbid diagnosis. Anxiety, depression is very common, bipolar is common, trauma is very common, PTSD, something like that. So lots of things to check out, to screen out, and the potential to be having multiple diagnoses related to these different categories. Body dysmorphic disorder is one that would be important to know. I think of this more with teenagers, high school age people, things like this. Um, Actually, at this point, probably could go to middle and even elementary school children, but this is also for adults too. So, preoccupation with perceived physical deficits or flaws, where people believe they look ugly, unattractive, or deformed. And the important part is that it's not noticeable to other people. So, this is not someone who has a major um, scar or something visible that's different for them, but it's something that the person perceives. So, for example, someone might think they have a really big nose and they're so worried about the size of the nose that they feel really unattractive, maybe even deformed. They don't want to show their face in certain places. And then we're going to see things like repetitive behavior, such as comparing. So maybe the person that feels like they have a really big nose, anytime they look at other people, they're comparing that other person's nose to their own. Very repetitive, very consistent. There a lot. And it's to the level where it's either causing that significant distress or it's impairing their functioning. So maybe they don't want to be seen, they don't want to go to work, they want to hide, something like that. Often this one is associated with high anxiety, social anxiety, a lot of perfectionism, could be a depressed mood, low self-esteem, and social avoidance. Again, higher in females. So good thing to be aware of. And then our last one for today, hoarding disorder, the one that's new to the DSM-5. Persistent difficulty discarding or parting with possessions, regardless of the value others may attribute to these possessions. Typically, that means the value of the item is really a low value, but they still can't part with it. For individuals who hoard, the quantity of their collected items sets that apart from people with normal collecting behaviors. It could be large numbers of possessions that often fill up or clutter active living areas of the home or workplace to the extent that their intended use is no longer possible. And this could actually become physically dangerous. So, a very common one is collecting old newspapers or magazines and never wanting to throw any of them away. So, obviously, a used newspaper does not have a lot of value, but they might save every newspaper they've ever read to the point where it's in boxes that clutter up the space, maybe clutter up the stairs, becomes difficult to maneuver around, can become dangerous if people could trip or fall because of all of these items that are in the way. So there is some of that clinical impairment. Even if the person is not distressed, they're impaired in that they can't even maintain that environment that is going to be safe and pleasant for themselves and others. Um, and this could be something that is distressing to other people and causing challenges in relationships with other people. So maybe family members don't want to come over to their house anymore because their house is so disturbing to the other person. And then there's distress or stress in between the family members, the ones that are hoarding and the ones that don't want to visit. So that's the kind of thing that you might see. There is also hoarding of animals. I'm sure you've all seen something like that in the news or in TV shows. So you kind of know what that looks like. Okay, and with hoarding disorder, that's one that you're probably not going to see a ton, but it's pretty specific and pretty easily identifiable when it does happen. And you may not be able to do much as a in the office therapist. That's one that can be really useful to have someone working in the home to work on some of those challenges. So that's our last diagnosis for today, and we're going to go ahead and stop there. We will talk more about some of the others on our next session.